All right, let's get started. Thanks so much, everyone, for coming. It's good, really, really good to see everybody today. And we're here to celebrate this year's, plural, recipients of our Global Health Prizes. And it's great to say plural because our donors, and you'll hear from them in a second, have sequentially donated the funds through endowments to support, first, the student prize, second, the faculty prize, and third, just this last year, the residency prize. So they're just tremendous, tremendous people. So I'm Glenn Galton, the director of the Center for Global Health. I have almost nothing to do with today's event, thanks to Alejo and Megan, and I don't know if others are here, but others in the center who set all this up. So, and arrange, our selection committees who meet and all this. I don't participate in the selection committees because I'm too biased in different kinds of ways. So I'm as surprised as our recipients always, and always pleasantly when I see the award winners. So let's hear from Bob and Leslie. Bob is a graduate of our medical school, 1959, no one reminds me, and just incredible, incredible people. And all of our recipients, thankfully, get to spend time with Bob and Leslie. They did that a few weeks back. And it is an amazing experience because they are incredible, incredible people who have spent their lives here in the United States working, but have done so much. I couldn't count the number of places they've been. I think they've lost count. Certainly every continent, but literally hundreds of countries that they've been in, most of which they've worked in. Bob has been the dean. He's a pediatrician, applicable to Andrew in particular in his award. Was a dean of pediatrics at Tulane, but has also started a whole bunch of medical schools, both here in the States and globally. So he's really just an inspirational person. And Leslie brings to the equation kind of the prodding and the nudging that our best partners always do. Well, what about this? And she's chiming in about this or that always. And I think a lot of what keeps Bob young is frankly Leslie, I think. So let's hear from the two of them. If we could play the recording for Bob and Leslie.
I'm Bob Suskind and my wife Leslie, and global health has always been a part of our entire being. It's hard to believe that so many years have gone by. I graduated from undergraduate school and the medical school back in the late 50s and early 60s, actually 1963 from the medical school, 100 years ago. And then we didn't have global health. I was the only student in my class who did anything in global health. The impact of global health on my own career and our family's life has been very significant, and it lasts even up to this day. And as a result of it, we established these awards at Penn to recognize the contribution that global health has made to the medical school and to the university, and to encourage all of you to continue on in the field. Well, we want to congratulate Andrew, Ellen, and Owen for having received the Global Health Awards this year.
If I were to say any kind of advice, I say try to help, because we are one species on one very, very vulnerable planet. And it takes people like you who have an interest in helping the world that may make all the difference, that will make all the difference. So I say to you, not only I'm happy for you in this award, but bravo to you for your intentions.
And I want to congratulate the leadership of the Center for Global Health, Glenn, Megan, the whole team,
yes,
for what you have done to develop the program to the level that it is now, recognized as one of the outstanding global health programs in the country. So congratulations, keep up the good work. and we will be with you as long as we can.
Bob's the only person I know that gets more emotional than I do about these. So you can tell that we're like 3 times in the taping because we had to edit the tape. That he's incredible. Okay, as is Leslie. So I'm going to begin with our student award. We'll then move to the resident award and then the faculty award. So our student recipient is Owen Parra. You have a description of Owen and his work there. I'll do a brief version with a little bit of an add-on. So Owen is a graduating student this year, 4th-year medical student here at Penn. I won't say the name of our medical school because when I came 46 years ago, it did not have a name appended to it. So I still think of it that way. Prior to medical school, so he graduated undergraduate from Tulane. Prior to medical school, spent years, 3 years, in fact, working in an HIV prevention community clinic. And, you know, you're in a setting like that, you see all kinds of people from all kinds of places. And this was I think, maybe the genesis of what inspired Owen, one, to progress into the field of medicine and his dedication to helping underserved peoples. And he continued that in medical school. You know, I'm not going to read it, you know, a variety of locations while he was in school here at Penn, including clinical rotation in our flagship program in Botswana. And I would say, you know, in reading Owen's kind of summary statement, you know, his application statement or whatever we would call it, the things that maybe resonated the most, and many of us see this when we work globally, is there are many, many commonalities that occur in the practice of medicine, certainly the need for care, and those are constant, and so there are lessons we can learn and translate to other settings. But those are always cast on incredibly different environments with different kinds of people who approach the challenges that I guess we'll all face in time if we haven't already in the need for great care. So Owen, come on up. Congratulations.
Thank you. My name is Owen again. I'm a 4th-year medical student. I will be graduating in just a few days from here. I just want to start off by saying thank you to the Suskinds and to everybody on the selection committee for this award. It really means a lot to me, and I'm honored to be here with you all today. I just wanted to speak a little bit about myself and just what global health means to me, as well as kind of my journey. Got a little brief summary statement, but just going a little bit into my background. I was born and raised in Kansas City, Kansas. That's my whole family here. Happy that a lot of them are here today. I get to go back and visit them quite a bit, but it's nice to have them visit me in Philly for a change. But I grew up there most of my life. I come from a mixed background, so my mom's family is German and Irish, and they've lived in Kansas for a little while. And then my dad's family, my grandparents immigrated from Cuba. So they immigrated from Cuba over to Spain and then here to the United States. My grandpa in particular was studying medicine down in Cuba before he fled in the 60s to Spain, where he finished his medical studies in Salamanca before he came here for residency in the US. And he ended up becoming a family medicine practitioner. My dad followed in his footsteps, also became a family medicine practitioner from the University of Kansas Medical School. And I'm following in their footsteps in internal medicine, so close, but not quite the same. But I'm still kind of modeling a lot of my career after what they did. So when I went to undergrad, I already had medicine on my mind. It had been something that I'd seen throughout my whole life. So I initially was studying neuroscience and psychology, but when I was there, I discovered a few small classes that were in international development, things that were really focused on public health policy and just public health initiatives across the globe. And I really fell in love with those classes. They were my favorite classes that I took the first few years that I was there. So I ended up pursuing that as a more formal degree as well, in addition to these other studies. And as I was deciding what to do with the rest of my career, I decided to take some years out before going to medical school and focus more on the public health side of things because of these studies, which led me to work at this clinic here. So worked at this small little clinic in New Orleans called Crescent Care. A lot of what I was doing at that time was around HIV prevention within the city. Would do a lot of harm reduction, a lot of HIV testing and linkage to care. Worked alongside a lot of primary care and infectious disease physicians, And then I also just did a lot of research into different barriers to care that various underserved communities helped or faced. We served a lot of different communities, including undocumented individuals, people from LGBTQ plus communities, as well as people that were without housing, people that were impacted by substance use. So a lot of my work was in this building right here, but most of my work was really in the field. And that's what I really fell in love with when I was there, was getting to really be on the ground and go into these different communities, meet different community leaders, get a chance to really understand what their lives were like, what the barriers that they and the people in the community faced, and what they really needed from the healthcare system. We were able to get a lot of people that had fallen out of the healthcare system linked back into care through these initiatives, and we truly would go anywhere. I mean, this building right up here is an abandoned Navy base that we would go into a couple times a month and just meet people that were living in there, go sit with them for a few hours, talk to them, provide them resources that they might need, and then we would see them in the clinic just weeks later. We would go to encampments, we would go to churches, community centers, all over the place. We would work in the garage doing harm reduction, giving out clean syringes for HIV prevention, and then just distributing a lot of different resources. So this is really where I found the world of public health and just realized that I wanted to be on the ground, wanted to be working with people. But this was also at the time of COVID. So about 6 months into working there was when the pandemic hit. And at that time, I was working alongside a lot of primary care and infectious disease physicians that were dealing with that, which is what really ended up inspiring me to venture back into medical school, because I realized that there was a way to merge this public and eventually global health interest with the practice of medicine, where I could really have an impact on patients' lives. So that led me here to Penn. When I interviewed here, one of the things that stood out to me most, I remember talking to my interviewer on my interview day about the global health opportunities and how you could get some early exposure, but also how there were so many different programs that would send you abroad and actually get you on the ground, which was really what I was looking for. So that put Penn right at the top of my list. When I first got here, within my first year, I started working at the Penn Refugee Clinic as a volunteer, would meet with people who are seeking asylum here in the US and help them follow up after their appointments, make sure they got their medications. Also started working at the Center for Surgical Health that first year, which is where I got a little more in-depth work with individuals. I would spend months and months with them, helping them get emergency insurance for surgeries that they needed, and going to appointments with them, following up with them, following the procedures. I actually ran into one of them just a few months back. He recognized me in a coffee shop, and he was an undocumented individual, but he has since been able to get his documentation. So I was really happy to see him, and he came up and gave me a big hug. So I did that for my first few years here. My first summer here, I also continued some of my public health work through my internship at Philadelphia Fight, which was a lot of similar work to what I did in New Orleans, but with mostly adolescents. And then more recently, I've taken on some research as well. I work with Dr. Bill Short, and we are studying some of these novel HIV antiretroviral regimens that are long-acting injectables that can help with people that struggle with adherence to oral regimens. So we've been doing a number of different studies on these with the main focus of eventually reducing perinatal HIV transmission, which is a major public health concern in the US, but the highest burden of perinatal HIV transmission impacts the area that I have gotten the chance to work in now and that I hope to continue working in the future, which is sub-Saharan Africa. So this all kind of culminated in my global health experience, where I got to go to Botswana this last September. Again, when I came to medical school, I knew that this was something I wanted to do, and so it was really exciting when I actually had the opportunity to do it. I was a little nervous because if you like something a lot, it gets built up in your head a little bit, and then you don't know what happens when you actually get there. So when I got there, I didn't really know what to expect. I had read about this for years. I'd been looking forward to it for years, and it was truly the best experience I've had of medical school. I would say of any rotation that I did, it was the most comfortable that I felt the entire time in a hospital system. And I think a lot of that ties back to the work that I did in New Orleans, because I felt kind of at home. I felt like I was on the ground working with people and getting to actually speak with them and understand their problems, getting to know community leaders. And I learned a lot in that time. I'm interested in infectious disease. I saw a lot of infectious disease. I'm interested in public health, and I saw a lot of the ways that social determinants of health impact people across the globe. And as alluded to a little bit earlier, I think one of the main takeaways that I had from this was that it was not very different than what we do here. A lot of the ways that these physicians practice was very similar, just in a different context. And even despite these resource limitations, there was always people that were looking out for their patients, and that was really inspiring to me. This is just me at Princess Marina. So I would say that this experience was a really great learning experience, but beyond that, it really transformed what I want to do with my career. I had been interested in global health, but this was really a confirmation that this was what I wanted to continue doing with my career going forward. I actually interviewed for residency shortly after this, and I did not include a single program that did not have a global health track in it. Every single program that I came to, that was my first question. I was like, what global health opportunities do you have? When can I go abroad? How early? And that all led to me matching at NYU this past March. So I'll be moving up to New York here shortly, and I'll be predominantly working at Bellevue. I've already actually connected with the global health director. She did interview me personally. And we'll likely be going to Ghana as well as potentially some other places. Yes, thank you. And also excitingly, my clinic will be at Bellevue, and so most of my patients will be refugees and asylum seekers, which I'm very, very grateful that I get that opportunity. And then the future plan is to eventually go into infectious disease and continue this work. I love doing this clinical work abroad. I love the research that I get to do, and I want to carry it forward. A lot of people to say thank you that got me this far. I mean, the Penn Center for Global Health, I just am so grateful to you all. These have been just incredible experiences. Everybody at the University of Botswana and in Botswana that I got to meet. Right here is Tiny. She hosted us in Machuti, and she's the best. And these were my co-meds as well. So I met some great people over there. So I want to thank everybody here, and then also my family. Just thank you for everything that you've done for me as well. And lastly, I just want to thank the Suskinds. They are incredible people. I am so fortunate that I got to meet them a little over a month ago. I have been extremely inspired by all the work that they've done, and I really will probably be modeling most of my career after what they've done as well. And it's just an honor to be a small part of their legacy. So thank you.
Hello, my name is Megan Daugherty. I'm the Director of Operations for the Center, and I have the pleasure of introducing our inaugural resident winner. So we now will have a fellow winner next year. This is all under the Suskinds, so we're delighted to continue growing this. So you all have Ellen's, Dr. Boachi's bio, so I won't read that, but I wanted to read some of the characteristics that were noted about her in her nomination letters, so you can all understand why she received this. And I'm just going to read like a list. So from leadership, including one of them right here, Dr. Carol McLaughlin, exceptional leadership, humility, collaboration, prioritizing local perspectives and sustainability, commitment, durable capacity building, trust, culturally responsive care, a focus on populations that have been historically excluded from cardiovascular care, a STAR, compassionate, high-quality clinical care, seeks to close gaps in access, a can-do attitude, inspirational, an advocate. And now from a peer, I absolutely love what the peer wrote. So some phrases. Rare to encounter someone of her stage of training with such a cohesive and wide-ranging skill set. Refreshing sense of positivity and genuine enthusiasm. Realistic understanding of the effort required to achieve meaningful change. Clear sense of purpose grounded in both hope and possibility. And I think this is my favorite line. Her passion and perspective continually reinvigorate my own commitment to the field. And something else I wanted to highlight that I know she won't say that I love telling people, especially the Ghanaians in the audience will appreciate this. So she attended the University of Ghana Legon Medical School. During her time as a medical student, she seems to have won the best of awards just about every year, including one, I don't even know how this is possible, overall best student awards, plural, in community health, obstetrics and gynecology, surgery, medicine, and therapeutics. That was just in one of the years. I'm not done yet. I'm almost done. Then she won towards the end, towards the end of her schooling, she won the prize for overall best student from the Ghana Medical Association, but still at her university for final part 2 of examination. Then she won the Ghana Health Service Prize for all-round best medical student throughout medical school, still at her one medical school. And I know a lot of medical students from Ghana. These are very, very, this says a lot to be the number one in all these. And then finally, she won Best Medical Student in all of Ghana. And that was from the People's Choice and Practitioners Honors. And I did a little research to see what those numbers looked like. So in her medical school, there are about 150 to 200 per year, 1,000 medical students-ish total. AI didn't give me great numbers on all of the medical students of Ghana graduating in 1 year, but I got the estimate of about 500 to 600 total graduates in the country per year. So I wanted to tell you that because her humility would not actually tell you any of that. So congratulations.
Thank you so much, Megan. That was a kind introduction. So happy to be here and so happy to see so many familiar faces. There are lots of Ghanaians, there are lots of honorary Ghanaians, Megan, and a lot of people who are planning to go to Ghana. So I'm happy to be here. First of all, I want to take the opportunity to thank the Suskinds for their kindness in encouraging some of us in our global health pursuits by sponsoring these awards, and also by paving the steps for some of us to follow through. Owen's phenomenal work. Congratulations on all that you've done, and I wish you all the best. I appreciate the opportunity to talk about my visits to Botswana and our ongoing efforts to establish a point-of-care ultrasound program on the medical wards at the Princess Marina Hospital. But really, I want this talk to focus on some of the amazing people I've had a chance to work with in Botswana. So just to take a little bit step back on my path, just a screenshot of my path. I grew up in Ghana, and for most of you who've been to Ghana, I grew up in Kumasi, and that's where all my family is. But I moved to Accra, the capital city, for medical school, and that's where I was for about 8 years. Finished medical school there, worked for 2 more years, which is required of the Ghanaian government. And then afterwards, I moved to Baltimore for my MPH and stayed back in Baltimore for my 3-year postdoctoral fellowship. I must say that Baltimore really grew on me, and now I really consider Baltimore home. And then here comes Philly. I've been here for almost 3 years now, and Philly has given me so much, but key amongst them is the opportunity to visit Botswana twice. And I take this opportunity to thank my program leadership. I think Penn is one of the institutions that has been very supportive of my global health efforts. And I remember during my interview, I was actually supposed to be interviewed by Carol. And then I go into the interview room and it was a completely different person. I was like, are they really taking my global health pursuit seriously? But then I met Dr. Yehuda Mate, who interviewed me, and she connected me with all the right people. So just want to take the opportunity to say thank you all so much. And thank you for the Center for also supporting our global health efforts. And of course, in the next 6 weeks or so, I'll be heading to Boston for my cardiology fellowship. And the hope is that I would be able to pursue my global health efforts even in Boston as well. And like I said, I would use some of these slides to highlight some of the phenomenal people I've had a chance to work with in Botswana. So pictured here is Prof. Julius Mweta, who is the head of the the head of the internal medicine department and the cardiology division at the Princess Marina Hospital. And this is us smiling after a very busy cardiology clinic. And Carol would always check in with me, and I'm like, I'm actually now coming from clinic, and it will be like 7 p.m. So this is us smiling through the busy clinic. He has been a phenomenal mentor. The clinics are usually very busy, but he takes his time to like teach me, allow me to teach the medical students, and so that has been really good. And then these are some of the supporting staff at the clinic. They are phenomenal. They multitask a lot. They triage the patients and then come into my consulting room to help interpret my conversations with patients. So I really appreciate them as well. And just to talk a little bit about our project, I wouldn't belabor too much on it, but I must say that some of the amazing clinicians I've worked with are actually clinicians in Botswana. And through their thorough physical examination, history taken, most of the time are able to get to the diagnosis and then treat the patient appropriately. But there are some circumstances where complementing physical examination and history with imaging or other like diagnostic modalities is really not optional and it's really necessary. And that's where some of the care gaps come in. And I must say that at the time when I was there were some challenges getting access to some of these imaging modalities. And even for the ones that were available, there weren't always specialists to perform these modalities or even read these modalities. And that led to delays in treatment. Pictured here is the famous echo machine that we use at the Princess Marina Hospital. We use this echo machine for both inpatient and outpatient echoes. And I must say that there's always a long queue outside this room of patients coming in for echoes. And some of the inpatient requests for echoes could be as simple as, does this patient have a pericardial effusion? But these patients still need to be wheeled into the echo place and wait for this to be answered. And sometimes that can be very frustrating. Pictured here in the white shirt is Dr. Roni. He is a Cuban cardiologist who is currently on contract with the Princess Marina Hospital. And he is a phenomenal cardiologist. He does all the outpatient and inpatient echoes on non-clinic days. And I must say that he had been very patient with me. He would actually allow me to go open the echo lab early enough just so I can take my time and scan patients before he gets in. And he's been a phenomenal teacher. So I just want to give him his flowers. I must say that he's phenomenal, but sometimes giving the patients numbers, we all get really overwhelmed. So I say kudos to him for keeping up. And so that brings me to our project, which is establishing a point of care ultrasound program among the medical students, internal medicine residents at the Princess Marina Hospital. And POCUS is simply bringing the imaging or the scanner close to the patient and answering a specific question. For example, like I mentioned, sometimes some of these patients are brought to the echo room just to answer a simple question like, does this patient have a pericardial effusion? Or is this patient who is coming in with heart failure symptoms, does he have reduced ejection fraction? And these are questions that can actually be answered at the bedside and not have to bring the patient all the way to the echo room. And most of these devices are battery operated or chargeable, and so they don't need constant supply of electricity to work. And thankfully, for both of my visits to Botswana, I was lucky enough to go with a handheld ultrasound device, and we were able to do some of these diagnostic tests with the handheld ultrasound device, like identifying pericardial effusions, identifying pleural effusions or pneumothorax, and not having to wait to book to get an X-ray done. And so that was really helpful. And also, POCUS can be used to bridge the diagnostic gap. I was so used to seeing like ultrasound-guided procedures here that when I saw one central line placed without guidance, it was almost traumatic. But, but using point of care ultrasound, some of these can easily be done. During my first visit, there was a patient that had come in with central line associated bloodstream infection. We tried treating through the line, but then she wasn't getting any better, and so we took out the line. But she had a very difficult peripheral access, and so she wasn't getting her antibiotics because we would always try and not get it. By using the ultrasound, we were able to place a line as frequently as she lost it, and she was able to complete her treatment. So these are some of the gaps that a point-of-care ultrasound device can bridge. And there's real-world evidence as to how these machines can be sensitive in picking up most of the common presentations that patients come in with. I wouldn't be painting a good picture if I don't talk about some of the implementation challenges we faced so far and some of the challenges that we anticipate to face. First of all has been the cost and process of procuring these devices. We had applied for a grant here at Penn. Unfortunately, it wasn't funded, but we are not relenting in our efforts. We'll continue to apply for grants until we're able to get these devices. And then a few other challenges like the training. Fortunately for us, the residents and the medical students are willing to train. I think the question always is, are you going to leave this machine with us when you leave? And then the answer is, unfortunately, it's not mine. I have to take it away. And so at some point, I actually stopped taking the machine to the ward because it was almost cruel to dangle this machine in front of people and have to take it back. And so the hope is that the next time that I go, I would have one machine that would be for the medical ward. And so this is the grants that we wrote. Unfortunately, wasn't funded, but we would present it elsewhere. And then in terms of way forward, we are continuing to explore other funding sources. And whilst that is in the works, one of the advice that I got from one of my global health mentors is to continue showing up to strengthen some of these partnerships that I've built. And so my hope is that as I go to Boston, I would still be able to go to Botswana and strengthen this partnership. And even whilst I'm still here, I'm staying in touch with them. And of course, I'm open to ideas as to how to move this project forward. And more importantly, how to make it sustainable. I share this with Rooney's concerns. So even whilst I've been back, he's been sending me echo images on WhatsApp for us to chat about. And so talking about staying in touch, this has been very helpful. And I want to wrap up by saying a big thank you to Dr. Farouk Darko, who is pictured on closer to me. He is currently the head of the BUP program, and he was very gracious to lend me his very expensive device to use, which I protected with my life, and handed it over to him before I came back. And of course, all these phenomenal mentors, time would fail me to go through all of them. But I was able to sneak my mom in there at the bottom. For the most part, she doesn't know what is going on with my career, but I'm sure she's proud of me. And special shout out to the people at the BUP office, particularly Josephine, who says she's going to keep my Botswana license active, hoping that I'm able to come back, even whilst I go to the Brigham. And of course, Dr. Mate is here as well. She always celebrates my victories with a good dinner. And so I really appreciate that. Thank you all so much.
Everybody's happy and celebrating, and there is a lot to celebrate even in a challenging time in the world, as we say, particularly for many of our global colleagues. So our last award recipient of the day is Andrew Steenhoff. And I've come to know Andrew very well, and we partner on many activities. And I have to say, always a tremendous, tremendous pleasure. In fact, we were just this Monday in Washington, D.C., meeting with the Namibian ambassador to the U.S. on a new project we're thinking about optimistically. Andrew's an endowed professor of pediatrics, attending physician at Children's Hospital of Philadelphia, CHOP for the uninitiated. He also directs CHOP's, or he's the medical director of CHOP's Global Health Center, which he's been doing since 2015. And I think it's fair to say Andrew embodies the spirit, both, not just of faculty, but of leadership in the institution and how we think and hopefully support all of our colleagues in developing their efforts in global health. So it's not just about Andrew, it's about what Andrew can do for everyone else. And I think he thinks of that long before he thinks of himself. Andrew received his medical degree at the University of Witwatersrand in South Africa. This was followed and developed his interest in pediatrics there. This was followed by time spent at the Royal College of Surgeons in the United Kingdom, the College of Medicine in South Africa, and then here in the US at Albert Einstein Medical Center, where he did his residency in peds, and then his fellowship in pediatric infectious disease at CHOP. I think the number is bigger than what I'm going to say, but Andrew has worked over 35 plus years in 5 different continents and 21 different countries, not just visited, but worked. And this encompasses so many different components and attributes and work in the global health space. But I think the key grounding feature was the time he spent with us in Botswana, where he was the head of research, the director of research at our BUP office, which is the Botswana Penn Partnership, which is a constellation of efforts between both Children's Hospital and Penn, working in Botswana. Ellen just presented Farouk and the team, and you heard from Owen as well about that effort. When he left Botswana, he brought with him just this world of experience and continued his work. And I know he'll say something about this, that as an infectious disease physician that began in Botswana, focused around HIV, diagnosis, prevention, care, or I should say prevention, diagnosis, and care. That has manifested over time as Botswana has done a spectacular job in their HIV program, thanks to Andrew and many colleagues at Penn and around, and Robert's here with us, for example. And that has morphed more recently into sadly, those other, things that we have to think about. So his tuberculosis as well, which he also began there and continues there to this day. So he's back and forth, even though he's based here now, primarily back and forth to Botswana quite frequently. This year, and we do this every year, we focus our faculty awards with a different kind of emphasis theme. And this year's emphasis was really on individuals who were not just great clinicians and great educators, and not just great mentors, but were team builders. And I don't think there's a better representative of that than Andrew. So, Andrew, come on.
Thank you very much, Glenn, and thank you to the Suskinds. It's a great honor to be here today. As I've shared with many of you, I feel like a team captain who's receiving a trophy on behalf of a big team. And the team at the CHOP Global Health Center, thank you to all of you and to everyone across this amazing campus. And thank you to our first 2 speakers who were phenomenal. Much appreciated. So briefly, I'm going to talk about 4 stories, and you can see pictures of these stories here. So by the end of our time together, you'll have a sense of how global health ties into these 4 pictures. I'm going to speak a little bit about the state of the world's children. Some of us are in pediatrics, others are not. A bit about the power of partnerships. We're in this incredible time where we work in an academic medical center. What can we do to advance child and global health? What's the secret sauce, though, to these partnerships? And then a little bit about impact. So in 2020 alone now, speaking about the state of the world's children, 5 million children died before their 5th birthday. This means that in an hour, 570 children died. So today, in the 2 hours that we together, over 1,000 children would have died in 2020. So this is a lot of deaths, and it's something that we need to be thinking about as a global community. What are we going to do about this? But what is killing these children? Why are children dying globally? And this report from UNICEF and the WHO was published in The Lancet. And it's a pie chart showing all the causes of death in children. And I'm going to take you to the 2 areas that I've circled in red. Top left for you, 1 to 59 months, and then top right is neonatal deaths. You can see that neonatal deaths, so this is deaths in children under the age of a month, account for 46% of the deaths of children under 5. So this is an important statistic because the first week of our life is our biggest risk week in our whole lives. And globally, if there's one place to focus on, it's really on that first month to try and prevent deaths. And you can see all the causes of death in newborn babies in yellow, and then the other causes on the other side. But let's look at them in a bit more detail. And now what I'm highlighting is all the causes of death that are caused by an infection. So I'm really glad that Owen's thinking about infectious diseases. So you can see TB, lower respiratory tract infection, sepsis, meningitis, and it goes on. AIDS, malaria, measles play a major role in infections in children as a cause for children dying under the age of 5. And so you might ask me, well, how important are infections? Can you put a number on it? And the answer is they're big. Infections cause 43% of child deaths under the age of 5. So if there are med students out there, or if they're residents and you're thinking of how can I make an impact on global health, consider infectious diseases, or consider fields that deal with infectious diseases. You might ask, well, what is the under 5 mortality rate like around the world, and how does it vary? And this figure shows us from UNICEF what the rates are like globally. Dark is bad, so dark rates means lots of death. And you can see, unfortunately, that sub-Saharan Africa has got the highest rate of deaths, as well as East Asia, Southeast Asia. Those are the two big areas. And then you can see here, I've done a little pull-out of a small island in the Caribbean, Hispaniola, which consists of the Dominican Republic and Haiti. And really the rates of child mortality, unfortunately, in the DR and Haiti are somewhat similar to sub-Saharan Africa. And that's part of the reason why CHOP chose to do a partnership in the Dominican Republic. So the deaths are occurring in sub-Saharan Africa and Southeast Asia. So where's the care? Well, this is a map showing where the doctors are. And here, dark blue means lots of doctors, and green or no color means less. And unfortunately, we can see that there's a reciprocal relationship. There are very few doctors in sub-Saharan Africa, and there are relatively few in Southeast Asia. But we all know that really it's about the nurses and the midwives. If you've got great nurses and midwives, you need a few doctors, but nurses and midwives are more important. But unfortunately, the story is the same. The number of nurses per population, again, much, much fewer in sub-Saharan Africa and Southeast Asia. So our little summary at this point is the state of the world's children could be summarized as there are a lot of children dying, 1,000 kids may be dying roughly in the time that we're together, that newborn deaths or neonatal deaths account for almost half of deaths under 5, that infections are a big player. There are other things too. And then where you are born counts, both in terms of risk of death, as well as who's going to look after you or who may not be there to look after you. So let's start here with Tandi, this mother who's looking lovingly at her child, Tandeka. This little child is 4 months old, is breathing fast, and has got pneumonia and is admitted to a hospital in Botswana. Now, pneumonia is a very dangerous condition. It's one of the top causes, actually, of death in children. And it's an important one for us to address globally. And the question is, what's going to happen to this little child? Is she going to survive? Is she not? And we have a group here illustrating the power of partnerships. Morgan Congdon, who is a CHOP resident or was a CHOP resident and is now a faculty member at Penn, along with Mamiki Chise, who you can see top right, who was a resident in Botswana at the time, now a pediatric oncologist, Francis Banda, a faculty member at the University of Botswana, and Matt Kelly, a former Pincus fellow, who's now a PEDS ID doc. And what this team decided to do with a number of other colleagues was look at pneumonia in Botswana and try to see what was going on. What's the death rate like? And importantly, what was the impact of what the Ministry of Health had done? The Ministry of Health in Botswana wisely decided to introduce vaccines, the pneumococcal vaccine and the Hib vaccine. And all ministries of health have to make tough decisions. Do you provide surfactant or do you do vaccines, for example? And so this team, working with the Ministry of Health, decided to look at this and see what the answer was. The good news is that after the introduction of Hib and pneumococcal vaccines in Botswana, there was a 50% decrease in pneumonia deaths in Botswana and a 48% decrease in pneumonia hospitalizations. The great news is they were able to present this to the Ministry of Health and say, well done, this is fabulous work. The ministry has continued to fund this vaccine program. Their leader in health is a different person to the person we currently have. And their immunization program continues with passion. They were also able to write this up in a manuscript, and this has informed World Health Organization guidelines as well around the world. So the WHO is prioritizing, encouraging countries around the world to roll this out at scale. So global health partnerships can do research that influences policy that saves children's lives. What about this picture? I showed you this earlier. You can see this is a gentleman called Dr. Madan, a senior pediatrician. He's teaching young doctors, including the first Pincus fellow, the tall guy, on second from right, Henry Welsh, up in a hospital in Francistown in Botswana. You can see it on the map. And there are a number of young doctors around Dr. Madan, and they're learning how to read a chest x-ray. This is a child who's got tuberculosis. Fantastic. This is what we do in clinical medicine. We teach those coming behind us, and then one day we say, I'm off on vacation, and now it's your turn to take it over, and hopefully you've learnt. That's all great. But what I want us to look at is something a little bit differently about this picture. What I'm doing here in the bullets is giving you a sense of where each of these young doctors trained in 2010. This young gentleman on the side here moved from Botswana and went to train in China, came back to Botswana. This young lady at the bottom went to Norway, learned Norwegian for a year, came back, did medical school in Norway and came back to Botswana. And you can see that young gentleman far left in South Africa, Henry trained in the US, and then the gentleman in the middle with the glasses on trained in the Caribbean, and Dr. Madan himself trained in India. And this is what Botswana was like when we as Penn started working in the country. Botswana would send their brightest med students or brightest students out, and many would come back, but only a third would come back from different parts of the world, and the rest would stay where they'd come from. And this was what it was like. And the government of Botswana said, we need to do something. We need to start a medical school. So partnering with Penn and with a number of other organizations, that's exactly what they did. So we were fortunate, I think, as Penn and CHOP to be able to partner. A new medical school was started in 2009, 2010, and there have been more than 500 med school graduates now with a number of residency programs, including in pediatrics. And so we can now relabel this picture in 2026, and this is what it would look like. When I go back in a couple of weeks, Robert's just returned. When we do rounds now in Princess Marina, not all, but many of the doctors have been through the University of Botswana system. And yeah, there might be the odd visitor from the US or elsewhere. And certainly there's still really outstanding doctors from other countries playing a role. My point here is that global health partnerships can play a major role in medical education to transform health systems. And this is what's happened in Botswana. What about this picture? This is a picture of Tuso. And Tuso is sitting in one of the rooms of Princess Marina Hospital, all the red roofed buildings of Princess Marina Hospital. It's a picture from a drone, perhaps. And little Tuso has just had his appendix out. And we've got, I know, a few surgeons in the room. Post-appendix, he's on antibiotics, he's looking better. And the question is, how well is he doing from an antibiotic standpoint? Are we giving him the right antibiotics? What's happening? Because antibiotic use, and particularly antibiotic threats and antibiotic resistance, are a major issue in global health. So again, working with the partnership model, one of the fellows at CHOP in ID, Ema Kit, who's shown here, worked with Lueto Majani, who at the time was one of the leaders in the pediatric department, to assess antibiotic use in both the peds medical ward and the peds surgical ward at Princess Marina. And the answer was, unfortunately, that appropriate antibiotic use, as defined by the World Health Organization, was 0% on the surgical side. That's a bad number. And that means too much antibiotic, too strong, or antibiotics not given. And I'm not looking at any of the surgeons, and this was a big issue. As Robert and other researchers in the room know, research is important. It allows one to pick up the carpet and look what's underneath. But it's not just about picking up the carpet. You've got to do something about what's under that carpet. And so next up, enter Dr. Bedada, top left. He's one of the associate professors in the surgical program at UB, the University of Botswana. And he said, this is unacceptable. We need to do something and we need to fix this. And so he reached out again to EMA and to others in the team and said, we need to do a quality improvement project. I haven't done one before. Can I work with you guys? Let's see what we can do together. And so he brought the surgeons together. They created 10 pathways for the commonest conditions: appendicitis, a urinary tract infection, brain abscess, and a couple of others, and said, this is what we're going to do. They agreed as a group at Princess Marina, and they implemented. And there was guidance for the junior staff, for the nurses, and for the attendings. And appropriate antibiotic use was measured for 9 months after implementation, and impressively, it went up 90%. Again, the power of partnerships, incredible colleagues, as we heard earlier at Princess Marina, but also someone who wanted to learn how to do quality improvement work. So we were privileged to be part of that. What about this lady? Let's call her Angie, and we'll call her baby Angelie. People understand the joke because we have a fellow in the DR called Angie, whose baby is Angelie. So when we first started working in the Dominican Republic in a rural town of Consuelo, we looked carefully to see what the rate of breastfeeding was. And the top 2 pictures here, I'm sorry, it's not a great picture, but this is Ramona and our first fellow, Lara, Pincus Fellow. Lara herself was a young mother. She knew how important breastfeeding was. Ramona's a dynamic community nurse, and she knows that it's about immunizations and breastfeeding and a couple of other important things. And they found that the rate of breastfeeding initiation in Consuelo was around 10%. We said, oh, this is terrible. What's going on in Consuelo? What is the rest of the DR like? And we were just exactly at the national average. It was 10% in the DR. When you drive around the Dominican Republic, you see big pictures of fat babies with formula. And there's been a whole cultural shift through advertising, etc., that really the way to go is formula. And so this was a really sad state. And so what happened is Ramona, Lara, and others developed a health promoter program in the community, worked with La Leche League and others, and really promoted breastfeeding in this town. And below these 2 is Angelie, an undergrad student here at Penn, who joined us to do this assessment, and Dr. Happa, the general pediatrician who worked with us for many years. And they did an assessment with others of how the program was going in 2023. And wonderfully, through all the hard work of the health promoters, Ramona and many others, the rate of initiation of breastfeeding in Consuelo has now gone up to 90%. So we've now shared these data with the ministry, as well as put it out and published it. Point being, global health partnership can make a difference when we work with the community and we work with amazing local community experts like Ramona. And my last story may be a slightly surprising one to you. It's just an arrow from somewhere to somewhere else. And that arrow is roughly from Botswana to Philadelphia. And I put this arrow up just to put out the concept of reverse innovation. As Glenn was alluding to, Botswana and many other African countries have done a phenomenal job from a public health standpoint and also from a science standpoint with certain conditions such as HIV. And so what Botswana found through really high-quality studies published in the New England Journal was that if a mother's got HIV or she's HIV infected, and she is well controlled on her medicines, she can breastfeed her baby safely. We have this U equals U thing, which is if HIV is undetectable, then then it's untransmissible. And so Botswana, as long back as 16 years ago, 2010, started data-informed approach of you can breastfeed, please go ahead. And breastfeeding, as we know, has got lots of advantages, including adding a few IQ points, which we can all do with. And so, ironically, we in the US have been a little behind on this. But the good news is that Liz Lowenthal, our research director, who was part of this initial move in Botswana many years ago, has now, with other colleagues in the US, moved the needle. And so the new US guidelines are now the same as they are in Botswana. So mothers can now choose in Philadelphia and around the US to breastfeed if they wish with these new data. And I think as we as a global community get closer, despite what some would tell us, we need to be aware of this concept of reverse innovation. We can learn from each other, no matter where we're from or where we practice. And I think we do ourselves a disservice if we're not open to the amazing creative ideas of our colleagues in low and middle income settings. So my mini summary too is that global health partnerships can advance child health using many different strategies. No matter what our skill sets are as academicians, they can do so in research through the pneumonia study, medical education through helping Botswana or other places get their training programs to the next level. We can help with quality improvement work, such as the antibiotic example, community engagement and public health, such as advancing breastfeeding and other relatively low-cost interventions that have major impact. And then we need to be open to and gratefully receive reverse innovation when we go to learn as well, because we will. So what's the secret sauce to these partnerships? You know, this sounds all so easy. Why don't we all just go out there and do it? And obviously, when I'm speaking to the converted here, we are all involved in one way or another. But I do think it's important for us to be thoughtful as leaders, facilitators, people stepping into this field to think about how this can be done and how it can be done well. And so the first brief point is practice and principles. These are 4 core practices that I do think are helpful in global health partnerships. And I think they're helpful in most partnerships. I think my wife and I use them in our marriage as well. Communication, certainly leadership, and it's obviously leadership here at CHOP and Penn, but also leadership in partner countries. Conflict resolution. I always joke with Maji Rankin, who's at the back and one of my amazing colleagues in the Global Health Center, that I really feel we're making progress in a partnership when we have a good disagreement and we are able to leave still as friends and partners. Because the ability to have conflict resolution and to do it well, I think is a critical component of successful partnerships. And then evaluation. And I think part of evaluation starts at the beginning. What are the metrics that we all want out of the relationship? And let's measure them as we go along. And then these are our 7 guiding principles of global health partnerships that were put together by a group of pediatricians from 10 different countries, which I think, again, are helpful to consider. We need to have partnerships that give mutual benefit. It doesn't have to have the same benefit, but there needs to be some benefit to all concerned. We need to be operating in humility as best we can. We need to be thinking about sustainability from the beginning. There needs to be inclusivity of everyone, everywhere. We need to prevent adverse impact. Sounds obvious, but sometimes we go in well-meaning. You hinted at it, bringing the POCUS machine. You were creating a sort of green feeling as people envied that. We need to be aware. Sometimes we might we might cause adverse impact. There needs to be a social justice lens through which we're working. And finally, we need to, wherever we can, bring equity. We have some resources to bring. Our colleagues have others. Let's bring those together. And so this was written up, as I mentioned, in pediatrics almost 10 years ago, and I think is a useful framework and one that we try to use as we build partnerships at CHOP and at Penn. But it's not just about that. We also, I think, need mentors. And I've put pictures of some of my mentors on here, some of my sub-Saharan African mentors and many of my pen and chop mentors. And I thank all of them. They've done many different things for me. They've coached me along the way. They've given me skills. And I think we, as we benefit from our mentors, so hopefully we too in time can become mentors to our partners around the world. So I think mentorship is a key part of global health partnerships as well. And then institutional commitment. I think we heard from the Suskinds how impressed they are with the progress in the Penn Center of Global Health. And I agree with them. I think the Penn Center of Global Health is doing brilliantly. But we need institutional commitment. And I show this at CHOP because when the CHOP Global Health Center was created almost 20 years ago, it was many of these folks who made that decision. And the CEO, the chair of pediatrics, Rodney Fanal as the first director, who were key folks. And then for me personally, Harvey Friedman played a key role in drawing me into the Botswana UPenn partnership, and I think laid a good foundation for many of us who've worked in Botswana. But we must remember that leadership changes, and leadership changes here, and it changes there as well. I often hear from folks, oh, it's changed in Botswana or Ghana, etc. And that's true. But we also have change in our leadership, and we need to ensure that institutional commitment continues. It can change, but we need to ensure that we keep the best part and then are open, obviously, to changes that enable us to throw out things that aren't working. So I'm obviously using CHOP as an example here, where you can see the transitions. The top left is Paul Offit, the division chief of ID 20 years ago, and now it's Audrey Odom-John, both very committed to global health. And you can see many of the other leadership here, our new chair of pediatrics, Jordan Orange, etc., and obviously Glenn, a key leader with Farouk of the Botswana UPenn partnership. So I think we've been fortunate, and I just wanted to acknowledge that to this group, that we've had excellent leadership and we've had committed leadership over the long term, and we appreciate that. And then, of course, it's not just about our institution, but we need to look out. And so I wanted to thank the funders who work with us. Danielle, I'm going to ask you just to wave, if you don't mind, as the leader of the Pincus Family Foundation. The Pincus Foundation has been our core funder at the CHOP Global Health Center, and without them, much of what I've mentioned wouldn't have happened. But there are many other funders who are on this list as well, federal funders, foundation funders, and then I've also put many of our partners here too, from Ghana, from Namibia, from Botswana, from the Dominican Republic as examples, because global health truly is a team sport. So what's the impact been of these partnerships? I've given you some nice examples. As Glenn mentioned, I've been involved in this for a while. I'm sure I could find something good to say. But let's be a little more objective. What's happening globally, and are children's lives being impacted positively as we take the longer view? And so children who died before their 5th birthday globally in 1990, the number was 1 in 11. That's a lot. So it's almost 10% of children who were born globally died in 1990. It's pretty hectic. What's happened since then? So in 2024, the number is now 1 in 27. So it's gone down to 3.7%. So it's more than halved. This is incredible. And obviously this is just one number reflecting so much work by so many all across the world, government level, et cetera, et cetera. But my point is child health has improved. We're going to see what happens over the next year or two. There are concerns that this may go in the wrong direction because, as we know, funding has been reallocated by many countries, including our own. So we need to keep measuring because we really need to be focused on the global health of everyone, but particularly of children. So we've spoken about the state of the world's children. I've just given you a little snapshot. We've spoken about the power of partnerships to have impact in many different ways. And you can choose whatever it is that you do, there's a way to make a difference. We've spoken a little bit about some of the secret sauce of partnerships and how to make them work well, and then a bit about the impact and a little cautionary tale that we need to watch this space. So to end, I'd like to end with a quote from one of my heroes. Nelson Mandela mentioned that the true character of a society is revealed in how it treats its children. And I'd like to invite each of us to either continue or to consider engaging with me and with many others to continue to advance both child and maternal and family health around the world. So before I say thank you, I wanted to acknowledge my wife and family. My wife is here in the front row, so she's still with me 25 years later. I just wanted to thank her for all of her support. As all of us know, in academic medicine and particularly in global health, it's a family commitment. I wanted to thank her and my son for their support during my career to date. So thank you all.
We have time for a few questions for Andrew. I've got one. I'll kick it off. So you showed the pillars, but in a very practical sense, when we think about creating partnerships, how can we position them so that we're sure that what we do has the greatest likelihood of actually being implemented long term? And you know, I gave the example of our visit to Namibia, where we're starting to do these things. But you've done this in multiple settings, because one of the frustrating things that I've heard among our colleagues over the years is, and I remember one coming from a colleague at CHOP, we did this in Botswana, we showed this effect on sepsis, nothing changed. So what are your keys, starting from day one, maybe even about how you pick the right partners?
Yeah, thanks, Glenn. And I think day one's the right answer, but I would say you even need to go to day minus 20, in that the pre-work is absolutely critical. So each of those projects that I illustrated, I think one of the items of success was incorporating local partners who had influence from the beginning. So the Ministry of Health was part of the assessment of the project, and I think that's key. I think a wrong approach, which I've done, is to do a great project and then knock on the ministry's door and say, can I give a talk? I think it's better to take more time to build a more complete team in the beginning, and then let it and journey together as one approach.
Yeah, it's a hard thing for many of us to do. We're very driven in what we do. We have our knowledge set in our field, and we come with ideas, particularly some of the more junior colleagues. This is what I want to do. Not the right way to do it. It's what do you need to do, right? This is exactly what you're saying. Other questions? Yeah, Robert?
Thanks. Really lovely talk, Andrew, and amazing outline on your career, and you've given us really phenomenal perspective, so congratulations. You pointed out that in the DR you were able to reduce the use of formula, which we view in medicine as a huge success. The companies that make formula consider it a disaster. And you've already pointed out that there are potential quote-unquote adverse effects. We wouldn't view that as an adverse effect, but somebody's losing money on the work that we're doing. I'm hoping, I have the tobacco companies not happy with me in Botswana, and I'm hoping that Liquorama will be next. So how do you balance, or how do you at day minus 20 factor in some of those effects that you might have that may make people cross with you and want to work at cross purposes against you?
Yeah, thanks, Robert. And for those who don't know Robert, this is an incredible mentor and someone who's done phenomenal things himself. So I appreciate your comments. Yeah, I think, for us as pediatricians, and I think we can expand the view, we operate with the child at the center. So I think our North Star is what is the best thing for the child? And then if we're working in internal medicine, maybe it's for the family, for the person. And I think we just have to get comfortable with the fact that some of the things we're going to do that are best for the child or best for the family are not going to be the best for others. Public health is going to divide opinion, and we know that it can be challenging. So I think again, getting the right partners in the room in a project such as yours is going to be crucial. Making sure that there's, as you probably have already, there's a person in the Ministry of Health who's involved. And maybe it even makes sense knowing the power of the lobby of both the cigarette group and the alcohol group. Maybe it makes sense to even think about knocking on the Attorney General's door just to begin the legal story. I work globally with a group called the Union Against TB and Lung Disease, and we take on tobacco there as well. And it's a very sneaky business, and they are prepared to play in rough ways. So I might suggest not only bringing the government on from a public health standpoint, but I might even ask the lawyers for some help as well, so that you can firm up a little for battles that might come. Yeah.
Any other questions?
Thank you very much, Andrew. I'm wondering, in the world of pediatric global health, thank you. Is there any movement when you talked about reverse innovation? This is kind of like boomerang innovation, I think, but about vaccines. Now that we're going backward and showing the positive effects in a global space, is there anyone working to try to counteract the information we're getting now, basically using the information
we're getting in the U.S.
Yeah.
to highlight how effective they are in other countries in the global space to kind of bring that conversation back around? Do you know of any efforts like that?
Yeah, it's a great question, and thank you for in some ways the prompt. This year's CHOP Global Health Conference, which will be October the 23rd and 24th, is about storytelling and advocacy in global health, and it's really to counteract that, because we all know we're in a 30-second world at the moment. If we can't get our message across in a video or a TikTok or some other quick thing, we're losing people, and we've lost some people. So that's why we're focusing the topic on that. And I've chatted with Paul Offit about this exact question, and he and the CHOP Vaccine Education Center are doing the same, trying to bring stories. Because what we found is when we've asked people in low and middle income countries about vaccine attitudes, they still remember the impact of measles, of polio, et cetera, et cetera. So they are not interested in alternative views which are a little off, which are non-scientific. So I think the short answer, Megan, is that we need more stories which speak to the truth, so that opinion can be swayed. Thanks.
Well, thank you. And in his typical fashion, he said nothing about exactly what he does, which is all those things, right? A lesson learned for many of you.